It's a great pleasure to.
Yeah.
It's a great pleasure that ISAR Gujarat chapter has been invited to a very important program of Maharashtra chapter of ISAR, its annual conference as well as National ISAR. And we are all here today for a very interesting talk on ultrasound in routine practice and basic infertility practice. What are the practical issues that we face? So we'll say if you want to start a follicular study in a patient, how will you proceed with US?
Sir, this is day to day. Every day we are doing ultrasound. And today in infertility area, we see ultrasound in a different way. Previously we are just looking uterus and ovary. Now we are looking this uterus and ovary in a different perspective. How would you like to do ultrasound in day-to-day practice? First is follicular study, because everyone we want very good follicle.
Yes, starting on the day 2 or just to evaluate the patient from the beginning.
Okay.
On
day 2 scan, you are just
on day 2 scan, whatever the management we are doing, it depends on that. Whether you are going for the IUI plant duration cycles or
anyway, if you want to plant IUI, if you want to do ovulation monitoring,
basic evaluation of the patient starts with the transvaginal sonography.
Yes, very good.
You should have a very good machine to see it for.
Okay.
It is better if you have a 3D machines for the all infertility evaluations, because it might help.
Everybody doesn't have 3D machines. Let us on the 2D baseline scan.
Baseline scan. In that scan, so see the uterus, see the ovaries, see the flow of the uterus.
Okay.
That is available in all the machines. See for on day 2, these are the basic requirements.
Would you like to see endometrium?
Endometrium on day 2 there will be not much will be seen in the endometrium.
But if it is hyperplastic then?
Yes.
So on day 2 baseline scan you have to see the endometrium, you have to see the ovaries, type of ovaries, normal ovary, PCO ovary, low reserve ovary, and you also think that on which day this patient could go for ovulation induction or IUI or IVF. Nidhi, what would you like to add? Just start.
The other thing I would like to highlight is to rule out cysts, because sometimes cysts would interfere with the stimulation. So
Yeah.
it also needs to be.
So resting follicle, resting ovarian cyst. Nisha?
Persistent corpus luteum also, there is a luteal phase deficiency which we can rule out.
Mehul, you are expert in IVF. What would you like to do?
I think everything is covered nicely.
Everything is
The
covered.
only thing we can add is look at the antral follicle count.
Yeah, fantastic.
So we can judge how you want to, if you are doing IVF, then what dose you needed and what should be the pickup plan. Whether it is a polycystic kind of ovary, then you have to go for a fusel protocol, and whether it is a poor responder ovary. So we can plan your.
So you are going on this direction. How you differentiate between functioning and non-functioning follicle?
Yes, exactly.
So-
Anybody opine on this?
See, basically functioning and non-functioning follicle, we can have a help of a color Doppler.
Very good.
If you switch on the color Doppler and if you see a nice color flow around the follicle, then it is a functioning follicle. If you see a dry kind of follicle, no much flow, then it is a kind of a
So you have to see whether follicle is green or follicle lying in desert. Desert doesn't have flow. Like green follicle has got flow. So always see the perifollicular flow, which will help in your cases.
And now there is one another point. If you see a follicle,
Yeah.
if you see a follicle, it may have not the right size, but still you find there is adequate flow. What have you to opine on this? Anybody can opine on this? The size is there for
Endometrium also at that point.
Yes.
That will also guide us, because if it's a thin endometrium, single line, then you are sure that it's a non-functioning follicle.
Very good,
So
fantastic.
you don't have to subject the patient to unnecessary estrogen levels and all.
And I think TSV also helps with the.
That will come later. Because this is the situation, sir.
Yes.
Mainly, sir.
correct. So here, when you came, the patient has come on day 3 showing below findings. Thin endometrium, left and right ovaries are as below. You can see them very nicely on the scan. So, what is your opinion? Dilip, can you tell us what do you think about it? You have your opinion on this.
Multiple follicles in the ovary.
Yes.
So it itself indicates a clear-cut case of PCOS.
Yeah.
Multiple moral rings.
Okay, so Dilip, it is PCOS. Now there is 3 different scenarios. This patient, if you want to do for ovulation induction, this patient for IUI and same patient for IVF. How you proceed? Okay, sir.
Yes,
this is day to day.
Absolutely.
So suppose one situation, if you want to give either letrozole or siphon in this follicular group, which drug would you like to give?
There is one irregular about follicle. I don't know what is the size in left ovary. So basically, I would like to go for a complete hormonal profile and follow-up of the patient in a mid-cycle.
Everything has been done. Now this patient is with you. Which drug would you like to give?
Preferably, I would if I see this picture on day day 2 or day 3,
This is day
then
2
I would like to postpone the stimulation. The ovaries basically left ovaries are not absolutely baseline. Left there is one irregular follicle which might be more than 12-13 mm size on left side.
If suppose same situation happen in next cycle also, then
Then I would like to synchronize the follicles by the hormonal therapy.
very good. Nidhi, how you proceed?
So, depends on how much time the patient has.
Patient is 28 years of age. Just active married life 1 year.
And then we can wait. But if the patient, we have patients who want to fly out immediately, they are from abroad, I'll do a baseline E2. If I feel that she can be stimulated for ovulation induction, answer is letrozole because she's PCO.
Yeah.
I want a monofollicular development.
Very good.
If it is IUI, we will go with step-up protocol. We can start with preferably FSH, although there are no differences grossly, but FSH would be preferable for the gonadotrophins, and we'll go with a low-dose step-up protocol. If she's for IVF, then I would want to plan her for a freeze-all protocol and counsel her in advance. But if the patient has a short interval, as we said, then we'll go with a low-dose stimulation, and then we can even transfer if we're very confident about her stimulation that she's not going to end up in OHS.
Fantastic.
So there are a lot of categories, but it has to be 1, 2, 3.
Well, in that case, Nidhi, I would just like to supplement one point that when you are doing this, will you add a GnRH antagonist for day 11 or 12?
Not for IUI. I don't feel the studies have shown that antagonist is going to add to the cost, but will not translate into a lot of change in the results as far as the lipase rate is concerned. It could be added if we are in a conference here in Shirdi and we are afraid that our patient is going to ovulate.
I had one patient, PCO patient, and he conceived spontaneously 2 times, twice before and got missed abortion. So we were planning for IUI. So we monitored for 2 cycles. The patient 3 follicles of 15-16 mm collected spontaneously. Did IUI also, but didn't conceive. So then the 3rd cycle I added the antagonist to hold the follicles.
Okay.
And then she conceived in 3rd cycle to reach the follicle size of 18 to 22 mm by antagonist in IUI cycle. Usually we don't do use antagonist in IUI cycle, but in such selected patients it gives a result.
Maturation.
Manish, whenever there is a multifollicular response,
Yeah.
it is better to use antagonist.
Very good. Expert sir, would you like to say something?
Because that is out of my domain.
Okay. Sir, next question.
To achieve
What are the-
synchrony between to achieve the synchrony between endometrium and follicle, also we need to give antagonist sometimes.
Basically, antagonist give asynchrony, but here we have to make him to play synchrony. Yeah, that's fantastic. Sir, next
Okay. What are the signs of mature follicle? I would like the other expert to join on this.
Sir.
Again. Please elaborate the signs
What
of
are the
mature
signs of
follicle.
mature? How you can say this lady is ready to get married? Okay.
Signs of a mature follicle, we have to put the Doppler again. Size will be the first thing. Size will be around more than 18 millimeter, 18 to 20 generally they ovulate. But once you put the Doppler flow, we will be seeing more than 2/3 of the vascularity. Around the perivascular flow we can see.
Okay.
And there will be reduction in the BIS.
What about the cumulus infructus? If you say cumulus over there, then it will say it is already sign of mature follicle, plus more than 75% of perifollicular flow with a very good PSV and very good endometrial flow. You can say this follicle is or this ovum is ready to get married.
Right.
See achieved the puberty. Okay. Then
It is not allowed at puberty, sir, now in India. You have to wait till the age of
Regarding the size of the follicle, previously in all the literature it has been stated that 18 to 22 mm size.
Yeah.
But now the guidelines have changed 16 to 22 mm.
Size doesn't matter.
Size
matters.
Sometimes size matters,
Sometimes
but always size
doesn't.
See, for the size, I want to give one simple comment.
Very good.
Every follicle has a different size threshold.
Yeah.
In each and every cycle.
Each and every cycle.
So you should not consider only size. So sometimes it is 20 mm is a mature, sometimes it is a 25 mm is a mature,
Sometimes it is
18 mm mature.
16 also sometimes
So
mature.
don't predict that 20 mm give it.
So always see the how previous cycles he has responded.
Yeah, our expertise, but then would you like to
If you are monitoring the patient from 3-4 cycles,
Hmm.
you can make your own assessment.
Yes.
How she is responding to your stimulation or the natural way.
And-
According to that, you can find it out that this follicle is mature enough for this PD to go for the pregnancy.
So that's why you can see, that's why always measure your follicle and always have a previous scan report. Sometimes some patient ovulate on 12th day, some patient on 16th day, some patient on 18th day. So that we should know. Yes,
If
sir.
it is not a stimulated cycle, then 18 mm is optimum cycle.
Optimum
If
cycle.
it is stimulated, then 24 mm may be a good cycle.
So here in the slide that we have shown.
Sir,
what
this
will
is the
you do?
situation.
Yeah. What will you do? What will you do?
Nisha, this is the scenario.
If I am going for a natural cycle,
Sarfaraz, welcome sir. Array sign, bless you, your seat is better. Nisha.
is actually there you can see the more than 50% flow around the follicle, so I will trigger this patient.
So Nisha, you are looking only at the husband. You are not looking at the wife. Now see, there should be synchrony between husband and wife. If I call follicle husband and actual endometrium is wife, because endometrium we have to so many things. In husband only we are see the size. So here see the size of endometrium is 6.7. So there should be a very good synchronized marriage. Now Sarfaraz, would you like to add something in this scenario? 7, follicle is maturing. Very good.
I will look for doctor of endometrium.
So what will you do now? It is 6.7. Would you like to get this endometrium mature or you will get the childhood marriage?
No, I will get childhood marriage.
You are ready with childhood marriage? That's why this panel is there, na? Would you like to have a 20-year-old girl and 6-year-old child?
Yeah. But optimum endometrial thickness should be 8 to 12 mm. That is the
Literature says.
But pregnancy can implantation can occur in.
How many of you are
in
agreeing that
endometrium.
this should be endometrium should be given Istradam well rate? Mehul, would you like to give?
See, basically, we have to wait in this current scenario.
Yes.
Wait for
Because, as I said earlier, 20 mm is not the final verdict. So wait for a 22 mm, let the endometrium grow for a day or two, and then wait for the spontaneous rupture.
How many of you are agree with endometrium?
It's
Why?
waiting.
Eh? Yes, now you agree. Now goal change. Okay, thank you.
You are talking about this 6.7 endometrium or grown endometrium beyond
No,
6.7?
this situation, sir, you agree that we should give.
Yes.
Next question.
Okay. So where will you trigger? This is the next question. What is
At which side or which side?
After waiting for one more day.
Hmm?
After waiting for one more day of the
No.
previous
Again,
day.
now the scenario change.
Okay.
This is the scenario. This is your endometrium. This is your perifollicular flow. So see the size of follicle, good endometrial thickness. Endometrial thickness is very good going for the vascularity. Then this video is not running, otherwise it is a very good video.
There is a technical issue with the video. We will get practical next.
Okay, next. What are the signs?
Signs of ovulation? What are the signs? Or
Pre-ovulatory or post-ovulatory?
Post-ovulatory.
Signs of ovulation. So there is yes. So the endometrium, we can see the endometrium, transition of the endometrium from triple line to secretory.
Very good.
But it's not, it might not be very much obvious. Then in the ovary we can see the variant of the corpus luteum.
or there is
What
disappearance of the
or
follicle.
disappearance or collapse of the follicle, irregular or follicle,
And the presence
it's
of
free
fluid in
fluid,
pouch of the glass.
free fluid in the mouth of the glass. There is sign of this. Many infertile patients we see, the first time we see in the mid-cycle, mid-cycle or secretory phase, we can say the patient is ovulating.
So progestinization of the endometrium. Triple line goes, very good ground glass appearance. We can call it the pregnancy conducive endometrium.
Above all these things, patient will complain you. They have
Yes.
pain, pelvic pain, and getting little discharge because of the ovulation.
That is known as mitral smudge. So many times, so many women can have this mitral smudge. Sir.
Best thing to know the ovulation is you follow the patient. The follicle is there the previous day, next day.
Next day follicle goes.
Sometimes it happens the patient is sent to us, say on the 14th day, whether it is ovulated or not. On the
Yeah.
16th day, then it becomes difficult. So indirect signs like the endometrium.
If you are monitoring only then you
Yeah,
can.
then it is possible.
Mostly whenever we see for the first, even if we are not follow, even if we possibly got a regular follow, then also we can make out or we can judge that the patient is ovulating.
Yes, so we have to become a judge
Yes.
on that patient.
Correct.
We are the lawyer,
Whenever
we are the petitioner,
whenever
and we are the judge.
we have not followed the patient from day 2 or day 10, or day in the mid-cycle. Then whenever we see for the first time in secretory phase also, we can say, we can judge that the patient is ovulating.
Yes.
We can diagnose that.
Okay, so now how will you assess the endometrium by ultrasound? What are the parameters which you will consider?
Because
parameters to be considered.
ovum follicular maturity is synchronized, it should be synchronized with the endometrium. So if you consider ovum as a husband, endometrium is wife. Because in ovum we are only looking at the size. But in endometrium we have to look for so many things. Thickness, pattern, vascularity.
All these.
So one by one, sir.
So starting with the thickness.
Yeah.
Now endometrial thickness, as everybody has just said, that it is 8 to 12, but you have to measure the thickness in between those three lines, from the one hypovascular area to another. Second, along with the thickness, you have to see the endomyometrial junction.
Okay.
That will tell us about the many things. Second, pattern of the endometrium, whether it is a triple line, whether it is grade 1, grade B endometrium, because we will be saying hazy areas in between, sometimes it will be grade B endometrium. And third thing is the vascularity, where you can assess whether which
Now only
zone.
thickness, we will come to the vascularity. Thickness. What about this? Suppose we have got very much little bit of fluid inside the endometrium.
Fluid inside. Now it can be physiological fluid. It can
It
be.
is a physiological normal fluid, but how you assess the endometrium? It should be assessed in.
It should. That fluid should not be measurable.
Fluid
in
should
the
be
thickness.
excluded. So
Yes.
measure is there. You have to exclude the fluid,
Fluid.
and you have to
And
measure the endometrium. Here it is 6.5
Yes.
in this situation.
Another important point, very important, which has been shown on this slide is that what happens is there is a difference of endometrium actually when you measure, because a part of myometrium encroaches, it appears that this is endometrium, but that halo is not actual endometrium, it is the myometrium. So you have to exclude that part from measuring the thickness, otherwise you will end up with a wrong thickness, and therefore the whole balance of your judgment will be faltered.
It is known as hypoechoic subendometrial halos.
So that halo is important to be excluded from the measurements.
So every stage endometrium looks different, and we all know that how much should be the endometrial thickness. What about the pattern, Nidhi?
So usually it's the trilaminar pattern around the time of mature follicle when it is progressed to that stage. It has to be central line and two lines. In between we have the isoechoic area. So that is the type of pattern we would be aiming for.
Yeah. Is there any endometrial pattern? Because all the female has to be graded by one male, that is the Smith, who had graded the female vascularity in different A, B, C, D. नहीं पढ़ो.
So what I usually use is the Applebaum's criteria, which we have discussed some time back. So where the vascularity is reaching, so accordingly you can have levels of endometrium, and the ideal endometrium when it reaches the central echogenic line, that would be the best. But when it reaches zone 2, zone 3 or 4 also, the endometrium can be transferable and we can predict good outcomes.
So you can see a lady who is very thin become very good synchronized ground glass appearance lady. Am I right, sir?
Yes, absolutely.
How does ultrasound help to ensure welcoming endometrium, sir? Now you have to welcome the endometrium. That now Bharat is ready. She had already mentioned apple bump.
Okay.
USSR.
Vascularity.
Apple bump. The apple bump is just all the mandap,
Yes,
Gangotri, everything is
Okay,
there. There are so
okay.
many
The
criteria.
thickness, the layering and the motion.
Now all three things should synchronize.
Yes.
Thickness, triangular, I think 5 layer better, and then vascularity reaching till the central line of the endometrium from all the aspects.
And you have to see the endometrial motion. She
Yeah,
should be ready to get
endometrial
married.
motion, yes.
You see? She is coming,
That-
she is
There
ready.
is absolute correlation of actual physiology and endocrinology. So you have to combine all the three.
And we have to use color also. Doppler, endometrial flow, myometrial flow. Here you can see very good endometrial contraction. You can see now she is ready, that I am ready now. Let get sperm to enter inside. This is a mature endometrium.
Sir, one question.
Yes.
In FET cycles, when we give estradiol,
Yeah.
exogenous estrogen, when we see the endometrium on day 10,
Yeah.
it is 9.5 or 10 mm. When we see on the day 40, after 4 or 5 days, it's the size of the thickness of the endometrium reduces a bit from 10 mm to 9 mm or 8.5 mm. Is it a good sign or a bad sign?
It's called
Yeah.
endometrial compaction.
It
is
is,
a
yes.
good sign. When there is more than 10%, it gives the best result in IVF or whatever.
And put it on that size, you have to see what is the pattern of that endometrium. When you see the endometrium, it is 5-line or 5-layer endometrium. When reduced endometrium has got very good ground glass appearance, disappearance of all that 5-line with very good vascularity, even though there is 10% reduction on the size, this endometrium is pregnancy conducive endometrium. You can get ovum to get married, or you can implant your embryo.
It is the beginning of the most potent secretory phase, you can say. Because it is the secretory phase only that will favor the implantation.
See, basically at this
Not
stage,
only
we have to
proliferation.
switch on the color Doppler.
Yeah.
And if you see a good zone 3 vascularity, then little bit of contraction is accepted. So it is a good sign.
So, the vascularity is not good, it's not zone 3. Then should we proceed to the transfer?
Because it is a frozen cycle.
Yes.
Days are in your hand.
Okay.
So if you want to increase the vascularity, you can use so many
Yes.
drugs. You can
Okay.
increase the
But
vascularity.
still-
Give them the benefit
yes.
of male drugs.
Yes, but the thing is that the Doppler in infertility has no clear-cut guidelines or reliability.
We would. That's why this panel are there. That's why I said that color Doppler will help. If you are not watching good vascularity, there are things with which we can increase the vascularity. Sildenafil has got very good roles. You can use them to increase the vascularity. You can give it for 2-3 days.
from day 2 only, sildenafil with estradiol.
Yes, if you know that this patient is not having good, but on day 14, if you see like this, and if you want to increase the vascularity, you got all the window. Second thing, if you are not getting the vascularity, your all embryos are frozen one. Do this in next cycle. FET cycle has got very good control in your hand because your ovum are already, your embryos are already frozen one. You can proceed this patient to next cycle. That liberty you have, and now you know that this patient has got not very good endometrium vascularity on day 14. Start sildenafil from day 2. Am I right, sir?
Absolutely.
In
Sir,
fact,
just to add one thing,
Yeah.
there is a role of uterine artery Doppler on day 2 in such kind of patient.
Yes.
Don't wait for 14th day to see the zero vascularity. Go second day uterine artery કુવામાં હશે તો હવાડામાં આવવાનું છે. એટલે when uterine artery is not going to give a proper flow, of course endometrium is not going to have a good flow. So start ecosprin or whatever vasodilators you want to give from that day only, so that you can on 14th day or something you will get some.
That's why this patient is there. There is a cutoff of 3. If it is less than 3,
2.7.
2.7 or cutoff of 3. It should be less than 3. Less than 3 means it is 2.7, 2.9, 2.8, but if it is 2.5, then we are happy. Yes. Yes.
What Nisha is saying is different. 2.7 is a cutoff on day 2.
Day 2.
When you see a color Doppler of uterine day 2 less than 2.7, on 3 is a cutoff for HCG
name of
day.
HCG.
HCG day. So HCG day, when PI is more than 3, you should cancel the cycle.
Yes. That's what Mehul is taking. If it is more than 3.2, you have to cancel the cycle. Am I right? Everybody agrees? Sir?
Agree.
There is some endometrial basal RI. Now, Visha, you are very much expert because you are going every day Doppler and RI and PI and got these things.
So-
because you have got PI.
So my PI and RI clear. So that's the thing. So when the vascularity goes on increasing, the resistance will decrease. So that is the funda of the basic monitoring of PI and RI. So the higher the resistant index, there are the less chances of conception. And when they are lower the RI, that will be positive.
Fantastic, fantastic. What about the follicular RI? Sarfaraz?
Follicular RI is the same as this. If follicular RI is around 0.5 to 0.45, it is good for the conception.
Sir, would you like to add something?
No, he is right. I mean, this is the correct range for the follicular phase that has been mentioned. I think there is good approve of this. Anybody else would like to differ, then please, you are welcome.
Any role of PSV?
Yes. It is that. How should be? It should be always less than 10
Less than
centimeters.
10. It should be always less than 10.
Now
If
we
it
have
is-
so
if it
many
is
steps
20.
in follicular monitoring. Rule of 10, less than 10.
Yes, it should be more than 10 centimeter per second when we have mature follicle.
No. I have one question. If on the day of trigger, PSV is suddenly we found 20. So we can predict early rupture? Discuss.
It is a good sign.
It's a good sign, but
So-
we can't say it is an early rupture.
Okay.
Sometimes I want 2 roti, you want 4 roti, that may happen.
Okay.
But it should be more than 10. Upper limit we are not deciding, but it should be not more than 20-25. I have never seen more than 25 PSV in mature follicle PSV.
Okay.
Because if it is more than 20, then it is overburdened, it will get ruptured by itself. Because why there is a vascularity? When there is a very good vascularity, it is a sign of rupture.
No, we people encounter this problem in the case of IUI.
Yeah.
We are calling the patient in the morning, we are looking for the Doppler and we found 18-20 PSV. So we are confused whether we have to give trigger or we have to do double IUI.
Just do with the HCG and see after 36 hours whether it is rupture or not. Then you are your own judge that with this 20 PSV, you have got very good result.
You will hardly find any follicle which will not rupture if it goes beyond 25. Most of them. So if you have any resistance to that, please let us know. If you have encountered
No.
your clinical experience.
No, my question is whether we should do double IUI in this, we should do early IUI in this case.
No.
That is good. Because the thing is, even though we are giving trigger right now, follicle is going to rupture after 12 hours if PSV is very high. This is my confusion.
See, to do IUI is a different discussion.
This is
altogether.
different discussion.
But
talking
we have
about only
hours of
follicular
discussion
rupture, right?
regarding the timing of IUI, right? So this is not a platform to discuss
But the
that.
fundamental is that even process forms are going to remain in the track for 24 hours.
Yeah.
So that
Only one sentence I will tell you. It is a misnomer that you have to do IUI at exact 36 hours. You can do IUI after rupture or just before rupture. It is a 24 hours late time. So you have ample time to do IUI.
So this lady is waiting for you for 24 hours. Let's come together and let her marry. Okay. Now, Nidhi, you are doing 3D reconstruction. What is your role? Suppose in this type of situation you are confused whether this 3D reconstruction of Doppler follicular vascularity can give you very good idea. You are doing sono AVC and like this.
we can do, and it will definitely help. But if I talk about my practical take-home points, I'm not doing 3D reconstructions for all follicles. So,
But when in special situation, if situation like this 24 mm follicle with 20 PSV, now you are confused. Now you want to see the 3D vascularity. Not I am mentioning about the 3D reconstruction of follicle. You see, you can have a vascular flow also. You can see the very good vascularity going over there. If vascularity is more than 75% and follicle is getting very good vascularity on 3D mounting, because in 2D you will see only one, but in 3D you will see that from everywhere this follicle is get supplied. So in this type of situation you can use 3D reconstruction and you can go for trigger.
One of the important planes, the third plane which is missing, because in 2D you will see only 2D.
Yeah.
So 3D overview and then subject your trigger later on. Yeah.
So these all are regarding the endometrial assessment, how you can look for 2D and 3D. This is baseline scan. You can see uterine artery Doppler very well mentioned. Endometrial grading, grade A endometrium, grade B endometrium, grade C endometrium. This is the vascularity with RI and PI, and this is Applebaum classification in detail. This This is zone with the vascularity, zone 1, zone 2, zone 3. Seeing is believing. You just don't want to remember the gradings, but if you see that this is going right up to the endometrium, then it is at zone 4 and zone 3, and now with 3D we are doing vocal also, sir. And vocal is giving very good idea regarding the volume. The volume base tip is more than 7, it is better predictor of thickness. With vascularity, FI should be more than 20, BFI more than 5 space. So this is global vascular parameter. In this slide gives you all things regarding the mature endometrium, thickness, grade A, vascularity, endometrial RI, volume, FI, BFI and PI. So this is a sign of mature endometrium. That's why I am telling that you have to consider the endometrium. As a female, we have to look so many things. Okay, so just visualize the endometrium. Yeah, you want to get married, so you have to get all this 36 out of 36 goals should be mature. Then you will get ready with this marriage.
Another kind of need exam.
Can we judge luteal phase defect by ultrasound?
When you have a very poor flow in the follicle and it gets ruptured, that follicle might go into the poor luteal phase also, and you might predict in a very early phase.
When we see a corpus luteum and we switch on the color doctor,
Yeah.
we can see a very good vascularity.
Yeah.
Sometimes it is called as a firewall.
Firewall appearance or ring
so
of fire.
It is a ring of fire or firewall appearance. And when we switch on the values, then we see RI and all that thing. So RI should be less than 0.4.
Less than 0.4.
Then it is a good corpus luteum. And if it is more than 0.45 or more than 0.5, then definitely it is going for luteal phase.
Luteal phase defect. Fantastic. Now, PCO. Next 20 minutes we are going to discuss. Out of 10 minutes we are going for discussing PCO. Okay.
Yes.
How you diagnose PCO? There are so many different things. Now first it is PCO, polycystic ovarian disease, PCOD. Now you got polycystic ovarian morphology, PCOM. So PCO, PCOD, PCOS, and latest is PCOM. So you see so many difference in polycystic ovarian disease. Sir, starting from you, how you guide? Which criteria would you like to follow? 1990, 2003, 2006, and latest we have got 2023 also.
So I am following 2003 criteria. So according to that, went with the Rotterdam criteria.
Yeah. Rotterdam criteria going for 3 things: oligoevaluation, clinical, and presence of polycystic ovary. Nidhi, which criteria would you like to follow?
So, most of us would be definitely following the Rotterdam criteria, because androgen excess society criteria are a little more stricter, and they would exclude a few patients
Yeah.
sometimes.
So there is a very good breach. Suppose this is Amsterdam and this is excess, androgen excess. These are the things which they are not coming in PCO because of criteria. They are coming in the PCO because only 2 things we are visualizing.
One thing you will observe that in all the 3 criteria, androgen excess is present. In all the 3, despite their different parameters.
Anybody will agree on this 2018 international criteria? Mehul?
See, basically they are trying to do more and more refined.
Refined.
And they want to exclude some of the over-diagnosed cases. Right? So all PCOs are not actually needed all kind of a treatment what we give. So now the current status they have put a cutoff line of 20 follicle. So 20 follicle in each ovary. That is the criteria now.
Or more than 10.
Previously we were following 10.
10.
So now they are almost double.
Double the criteria. And also they put a word of caution, because in so many early pre-puberty girl, we see the diagnosis of PCOD. Please have a note that these are not the polycystic kidney, these are the multicystic kidney. And puberty age you will get so many follicles. Don't give them the diagnosis of PCOS, because now young adolescent girl just starting menstruation, they are going to say, I got PCOD, PCOD, PCOD. So I am also concerned. There is a PCOD. What is PCOD? But this is PCOD. So don't give them the diagnosis of polycystic ovarian disease. This all ovaries are multicystic.
Actually, let me opine on this very important. Recently, I have been honored as a patron of the PCO Society of India, and one interesting, observation which has been made recently is that the younger girls who are teenagers, you see, they have a habit of taking a lot of fast food and junk food.
Yeah.
This type of food is increasing and is rising obesity, and therefore you are finding more and more girls at the early stage to having more and more follicles. So we have to have a revised cutoff in this situation, and that is why we have to bring this important parameter which already my
Yes,
has discussed. Yeah.
PCO patterns. When we see PCO pattern in the ovary, it doesn't mean it's not necessarily a PCOD.
Yeah.
Yes. So subclinical hyperprolactinemia and subclinical hypothyroidism is very common in PCO patient.
Yeah.
It's not PCOD.
That's why now it's changed the nomenclature, polycystic ovarian morphology. So this is PCO, and this is latest study.
PCO pattern and PCOS or
Yeah.
PCOD is, there is much a difference between these two entities.
This is very good paper, our recommendation for 2023, that follicle number in more than 20, Mehul has rightly mentioned, and ovarian volume should be more than or equal to 10 centimeter per square. So now you should consider this as a rule, and this is just I had mentioned that ultrasound in early menarche, don't consider that it is a polycystic, it is a multicystic. AMH is till now not put as a diagnostic criteria, but now we see that AMH is always increased. Sir, what is your take on it?
Yes, absolutely. There is an increase in average.
Manish bhai, in my 33 years of practice, I have seen nowadays I have seen lot of unmarried and teenagers girls with the PCOS syndrome. The parents are coming with the complaint of obesity, later hirsutism and amenorrhea.
Yeah.
So it has increased rampantly. Very difficult. And I have asked them all to undergo the hormonal reports. Most of the time the hormonal report is normal, but they are always symptomatic.
They are always symptomatic, and if you see the uterus, there is always hypervascular stroma. Okay, on the ovary. So ovaries are thicker as well as multicystic, and that's why there is rule of 10. This is simple. Ovary rule of 10. Okay,
Everything is
10. Previously also then more than 10. So remember 10 as a cutoff. It should be more than 10 PSV and 10. Everybody agrees, sir? Would you like to add something? So this is latest. From Rotterdam, it came to this. Okay, this is 2023 criteria. Thank you very much. How will you identify endometrial polyp? Now this is day-to-day situation. Now we'll go for clinical situation. We've got 16 minutes left. So how you diagnose endometrial polyp on ultrasound, sir?
Endometrial polyps are best diagnosed pre-ovulatory,
Yeah.
in between day 10 to day before the ovulation. So we will be seeing the good round polyp. We will be seeing as a good round hypervascular structure.
Okay.
If we put on the flow, we can see the feeding stalk or feeding blood vessels to the polyp, and
So here color will help you.
yes, color will
When you are
indicate.
in doubt, just put color.
Yes.
Color add in your life,
Yes.
because this is male and female life. So put color.
Yes.
Don't give them the black and white picture. Everybody agrees that put color. Yes,
Suggests the appearance of
Yes,
You
one
can-
is a proliferative phase, is
Yeah.
the diagnostic point, and second thing, if you have still doubt, you can use sonosurfing.
Yes, SI.
You can put it.
Even 3D is helpful sometimes. What you cannot see on 2D, 3D you can still discover a polyp, and then you can you can add on the other measures which Mehul has just mentioned. So the survey.
Another thing, anytime you go for the ultrasonography, you will find a thick endometrium every time. Either it is proliferative phase or secretory phase. You will see more than 14-15 mm.
Then think of polyp. Now we are going from the elder brother of polyp, that is fibroid. Yeah.
Many times when we see echogenic structure in the endometrium, we diagnose the endometrial polyp.
Yeah.
But it might be a polypoidal endometrium, not actually a real polyp.
That's
Many
right.
times-
Here the vascularity helps.
Yes, okay.
If there is endometrium, then you don't get vascularity,
Vascularity.
as in the base. If there is a polyp, single vessel is going, always there is a feeding vessel.
Okay.
Whenever there is polyp, it has got single vessel with supply. In polypoidal endometrium,
Polypoidal.
there is a no vessel going inside the polypoidal endometrium.
Okay.
Simple differentiation. Put color if you, and when you are in doubt, you just put power Doppler. That feeding vessel has got very good vascular pattern. If it is a polyploidal and you see the vessel, it has got the same venous vascularity. there should be an arterial vascularity. So polyp is always getting fed by feeder vessel. If you see feeder vessel, then it is a polyp. If there is no feeder vessel, there is a polypoidal endometrium. Sir.
Yeah, basically all the polypoidal endometrium is supplied by the uterines only. It's the excessive flow from the uterine which makes it grow for obvious pathological reasons. But at the same time, as Manish has already mentioned, there is a single vessel which will be able to identify, if not on only color Doppler, you can use power Doppler for enhancement and you will get it.
You will get the vascular pattern because it is the arterial supply. And if you see this type of polyp, this identification of vessel will help you to in the submucous fibroid removal with your loop or with radial with your now we have got ultrasound probe to remove that polyp, and you can use loop. When you see when there is a feeding vessel, just coagulate the feeder vessel and slowly you can take out that polyp outside. Sir.
Yes. Now ultrasonic features of fibroid. What are the various features of ultrasound that you will discover for fibroid? Important, very, very important question.
Surprise. Because in Himatnagar there are so many fibroids. Yeah.
How will you say that this is a fibroid and this is not a fibroid? Clear answer.
Okay. Distinctive mass round in the shape, hypoechoic mostly, and surrounding myometrium. You have to compare the surrounding myometrium. It is rounded, it is distinguishing, and it is hypoechoic.
Yes. Very good. Fantastic.
Put in color and you will get a circular pattern.
Yeah. And there are different varieties.
Initially, when the fibroid is just very, very early growth, you will find it hypoechoic. But when it grows more and more, there is fibrosis, even calcification.
It can diagnose calcification.
Then you will see a heterogeneity.
That we can diagnose this is old or new.
So when we are putting any diagnosis, first we have to take genuine history. Always patient gives the history of irregular,
heavy period. And sometimes painful also.
Sometimes it was
Sometimes.
Or else it happens when you get the big fibroid without any symptoms.
Many of the time.
But most of the time, 90% of the cases, patient gives the history. So if you get the history,
So always ask the history. And Dilip bhai, what is the definition of history?
regarding
It is the study of past in light of presence to have good future. So always give thou ears. Become a very good listener. Yeshu Masih always says, give thou ears. Listen them carefully. Naturally, 80% of the symptoms or complaint coming from them.
The other practical definition is you increase your awareness to be more clear about the mistakes that were made.
Yeah.
see, Nimish bhai, when I was resident, Dr. Narayan Patel was our professor.
Yes.
So yes, when I was resident, we did not have ultrasonography machine. It was not there in the institute. So he always used to ask us that you should have the ectopic idea in your mother, only then and then you can diagnose the ectopic pregnancy. The patient is having the symptoms of the, you have to diagnose on the symptom that it is 100% patient of ectopic pregnancy.
Our teacher Nizam Yagnik says that if ectopic patient is coming, she is always coming like this.
Exactly.
And you have to just palpate on the abdomen. If there is a thrill, no need to do anything. Miss the period. When miss the period, it is bad news. But when Mrs. miss the period, then it is a good news.
Dilip, thank you for giving the name of my postgraduate teacher, whom I did, Dr. Narayan.
So this is Sarfaraz, you are talking about calcification and shadowing, and color always help because there is a fundal fibroid. Also we can take help of sonosalpingography. 3D has got very good evaluation. Now comes another brother, endometriosis internal, adenomyosis. Sir, cousin brother, how you differentiate between adenomyosis and fibroid?
I mean, adenomyosis, there will not be clear-cut differentiation seen in between the myometrium and adenomyoma.
Okay.
It will be diffuse of very few times you will be seeing it localized adenomyosis also. Now the various symptoms, as Dr. Nidhi has already elaborated, that there will be wall thickness. You can see the collection of endometrial cyst in the endometrium. So this all will be seen in adenomyosis.
So these are all the features: loss of normal endometrium, hypertrophy, Swiss appearance, sometimes sunray appearance, anopic cystic area, hypertrophic foci. Color Doppler, if you push, diffuse hypervascularity and can be diffuse or focal. So here also color will help you. This is the global enlargement, and you can say this type of appearance. You can have a acoustic veteran bands in adenomyosis that is absent in fibroid. And here you can see vascularity which is central. In fibroid there is a peripheral vascularity. If you see central vascularity, then it is the most differentiating feature between endometriosis interna or adenomyosis and fibroid.
In adenomyosis, if you do a very detailed vascular study, you will find that the blood vessels are very random. They run crisscross, and there is a completely disturbed circulation that will differentiate it from a very other normal anatomical structure, which is more correctly or constitutionally made as per the architecture.
So there is a chaos of vascularity.
Yeah, absolute chaos. There is absolute traffic jam, you can say.
And with 3D also this is very good helpful because you can have a loss of junctional zone. Okay, sir.
Yes. Now, which uterine Mullerian anomalies can be diagnosed by ultrasound and how? How many of you will diagnose Mullerian anomalies?
There is list of class 1, class 2, class 3, class 4, class 5. We have got 8 minutes on this, so we are going little bit fast. This is all are the different, but here 3D will help. Here 3D will definitely help. If you see banana, then think of unicornuate uterus. Okay, unicornuate uterus always look like banana. You can see there is a very good banana-like cavity, no second cornu is seen, and this will help you because now you are practicing IVF. Then you have to think of maximum implantation potential point. Every uterus has got different potential point. You have to draw one line from here, one line from here, and here in between you can put your embryo. So this is a maximum implantation potential point. So if you know the anatomy of the uterus or anatomy of the endometrium, then it will guide you where you have to put your embryo. Same will apply on IUI because we are not going beyond the internal loss, but in the internal loss in different type of situation it may be different. So you have to see uterine diagonal piece. This is how you can see on uterine diagonal piece. You can see 2 uterus on either side. Okay, your transabdominal ultrasound you can see biconate uterus very well. Here the cutoff point is deepening, endometrial deepening. So this will give you some different idea regarding the biconate uterus, subseptate uterus and arcuate uterus. So here you have to see the endometrial deepening. This is a typical biconate uterus. Now there is a septate uterus. Now you see this septum is going down. So endometrial deepening is too much roughly. Then you have to see the angle. On B scan you can see there is a very good angle. This is a septate uterus and this is a biconate uterus. You can see the endometrial deepening is very good. So there is a clear-cut demarcation of ultrasound. So with ultrasound you can differentiate arcuate, biconate, subseptate, different variety of uterus. Arcuate has got angle more than 90, where subseptate has got angle less than 90. Okay, so this should message go in your system.
Absolutely. Now, next question is how will you differentiate hemorrhagic cyst from a chocolate cyst? Chocolate cyst is of course the endometriotic cyst as we know, and a hemorrhagic cyst is after a ruptured corpus luteum. There is uncontrolled bleeding occurring inside the ovary, and that hemorrhage can be very of a large amount as well.
Nisha, how you differentiate?
Hemorrhagic cysts mostly have a mixed pattern of isoechoic, sometimes cystic with hyperechoic area, while chocolate cyst is thorough, round glass kind of appearance, same consistency throughout. Symptoms matter. As sir said, history. Chocolate cyst patient might have a history of dysmenorrhea, previous surgical history and all that.
So it is not difficult. On ultrasound you can have a very good differentiation of honeycomb appearance. You can see the vascularity. You can see the ground glass appearance. So this is not that much difficult.
One important differentiating point in a chocolate cyst, there will be debris 100% because it's the broken endometrium and the cells. In a hemorrhagic cyst, it's only clot. So that basic difference is that you should know.
And second thing, all the clots and debris, they are not very good reflector of ultrasound. So both look black because they don't reflect the ultrasound. The things which doesn't reflect, it looks black on ultrasound. But here you should differentiate between the too much black and little bit less black.
In that case, if you have any doubts, go for 3D. It will be still better.
And only think hemorrhagic cyst having a thin septa inside.
Yes.
So
that is a honeycomb appearance, you can say.
And the chocolate cyst is a
clear ground
glass appearance.
And always correlate with the symptom of the patient. There are different modalities to diagnose. How many of you are using this Sono ABC?
I routinely use.
You routinely use, and it is very helpful.
Yes.
It is very helpful, very good software. You can see so many follicles, and it is very good helpful to all of us. analysis of uterus with different cervical modes. This is TUI, you can use for it, you can diagnose polyp and everything. So always take the help of your machine very well. Know your machine, know all the knobs of machine, and use all the knobs of machine from the front and behind also. There are so many buttons behind from which you can have a separate transmission, you can have a study, you can have a lane. So all these buttons you have to use so you can diagnose very well. You can also see the complete vascularity with this. This is a very good vascularity with uterine endometrial septum. So with this, we are before time. Say bye-bye and Hare Sai. Both this baby wants to go to home because we have 18 hours journey from here to Surendranagar.
One important, please.
Let me tell, when we started our career for the ultrasonography, Manish, and 7 months in Nimish before, we had only one machine and that a linear probe.
Linear probe with 7 kg weight.
Yes.
It is 7 kg weight machine, 7 kg probe was there. Remember, and there is a small screen that is known as oscilloscope.
Yes.
We have to reconstruct the image from the dots. And only one joystick is available to measure the joystick. Only 2 buttons are there on machine.
Size of the screen was almost 6 inch by 6 inch.
6 by 6 inch. No, a small screen. Half of that screen.
Probe size and screen size was
No.
And Kazi, we become so happy after diagnosis certain things that we are able to diagnose this thing with the ultrasonography machine. So we feeling proud that we have diagnosed these things.
So we are on the era of Madhubala, now Aishwarya Rai is there.
Now,
Let me quote one thing. Sir. H.G. Wells, a great philosopher, has said that you don't wait for the storm to pass. You don't wait for the storm to pass to dance in the rain.
Yeah,
So
very
let the
good.
time come. Every storm will pass, but you start.
And Charlie Chaplin always says, always cry with the rain. Says nobody watches your crying. So men need this difficulty because they are necessary to enjoy the success, said by Abdul Kalam. Thank you very much. You have always flow. Yes, audience can
there
check.
is one important, but before you want to, this is a question you are asking?
Yeah.
Yeah, just ask please. Then I conclude with a very important
Elaborate
part.
something more about utilize unruptured follicle.
LUF, sir. LUF, utilize unruptured follicle.
Yes.
Elaborate something more about LUF. Many times we are confused whether to take it as ruptured follicle or unruptured follicle. So we are planning IUF, we see there is internal echo, but we are confused, size is little bit decreased.
That we have already discussed, sir, in our presentation, but again, Mehul will say.
See, when you see a corpus luteum and you are confused that this is a luteinized unruptured follicle or this is a corpus luteum, only and only crucial diagnostic point is a vascularity. When it is an active corpus luteum, then you can see a ring of fire appearance. And if you switch on the PI and RI mode, then you can see RI of less than 0.5 and 0.4 and the PSV more than 10 centimeter per second. So that is the absolute differentiating point between luteinized unruptured follicle and vascular corpus luteum cyst.
With a good resolution,
So you can definitely see.
with a good resolution scan, you will be able to also see a perfect evidence of rupture which is free fluid. Free fluid you should try to find out with the best resolution, even go for 3D if you have. And then if that is also another evidence, because with every rupture there will be a follicular fluid spillage into the peritoneal cavity. So it is one other evidence which you should try to find out. Now before we wind up,
Concluding remarks.
my concluding remarks are, I'm talking about the horizon. We all know about uterine transplant. And uterine transplant has been tried all over the world. It has been tried in Maharashtra, in Pune with some success. We also tried it in Gujarat at IKD. The experience today is dilly-dally because many transplants have failed and the uterus is getting rejected. The way out, which is now on the horizon, which the researchers are working on, is on ultrasound scan and monitoring the uterus after it has been transplanted, check the vascularity, day-to-day basis, because it will tell you whether these vasculature, when you are connecting an anastomosing artery to artery, vein to vein, whether that anastomosis is really working or whether there is platelet aggregation there. If you notice platelet aggregation with thick clots on the ultrasound scan earlier, you can predict that this uterus will get rejected. So this is on the horizon for ultrasound, which I have brought to your notice. It's very important to know. Let us hope that uterine transplant works later. Thank you.
Thank you very much, and everybody should be happy now. Play the audio.
जानी चाहिए एक्चुअली
So everybody should be happy.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
So I thank you, my all panelists, for giving the precious time. I also thank
The time to be happy is
Thanks a lot, our moderator, to make us happy.
Thank you, thank you.
On behalf of
Sir, we have good food.
my panelist member, I'm thankful to Manish Bhai and Amish Bhai for conducting a very nice panel.
Thank
We
you.
enjoyed it, we learned it.
Thank you,
Thank you.
Thank you so much. With this, meanwhile, I would like to announce the session 4, which is USG and KRT procedure.
Sorry, thank you.
May I acknowledge the presence of our chairperson.